All right. uh, some more people to admit. Can you all see my screen okay? Physiology of aging. I realize I probably bit off way more than I could chew here. Physiology of aging is probably going to take me 45 minutes, so we'll see how much we get to understanding mature adults. I'll be able to cover some of it, hopefully. So I'm going to go ahead and get started. To my knowledge, you guys are the first to ever see this presentation outside of Cody's students at the University of Harding. So this is a first for me delivering this, and first for anybody hearing it. So the Physiology of Aging is one of the modules. Basically what we did was we turned the manual into a presentation for you. Obviously there's a lot of reading material there. This is typically the module most people come away with the most depressed. They read it and they're like, man, this is not really good news. So there are some things about aging that don't necessarily have to excite all of us, but I saw your comment, Nikki. So just as a reminder, general framework, right? We're going to talk about physiology of aging across all these different 6 domains, more so in some as we see some of the impacts, but we always want to be thinking about that. So if we think about the musculoskeletal domain, I think that's where we're going to spend a fair amount of time, and then we're going to talk about the cognitive piece. You know, the musculoskeletal domain, we certainly see those physical impacts, right? Loss of muscle mass, loss of strength, loss of power. Make sure I've got everybody admitted. Loss of bone density, loss of collagen, loss of cartilage. Yeah, I mean, it's unrealistic for us to just assume that a 70 or 80-year-old has the same knee as a 20-year-old. They don't. They've got osteoarthritis. They've got thinning of their cartilage. Their joint lubrication has changed. Obviously, some have had joint replacements. I'll stop there for just a second because our training clients with joint replacement course really talks about the fact that there aren't that many people with joint replacements. Sometimes I think it gets too much attention. It's certainly a real situation, but only about 7% of people over the age of 65 have had a joint replacement. So sometimes we just think, oh, well, everybody over 70 has had their knee replaced. Not even close to true. It's probably going to climb to about 10% here in the next couple of years as now bigger and bigger numbers of people are turning 65, but it's still not as common. You know, osteoarthritis obviously is the most common condition of aging. We see more subcutaneous fat. We see more intramuscular fat. Unfortunately, people don't necessarily change their body weight tremendously, but they start to become fatter and less lean. And of course, that has functional issues, really does. So Michelle, it's all relevant. My 85-year-old client said to me today, if she could just be 15 years younger. Yeah, absolutely, for sure. I think that's, I would think the same thing at 45, right? If I could just be 15 years younger again, right? Back when I used to play basketball every day when I was 30. So we all sort of long to be 15 years younger sometimes, physically, not necessarily life and experience-wise. So, I mean, here's some cross-sectional pictures, right? The typical aging view. We start to see less and less muscle around that femur bone and more subcutaneous fat. But then the question is that really normal aging, or is that long-term sedentary activity, right? When we look at the 40-year-old triathlete, you know, we see a very lean cross-section, not much subcutaneous fat there, not much fat inside the muscle. And then we look at a 74-year-old sedentary man, doesn't look good, right? Lots of subcutaneous fat and actually some fat striations in the muscle tissue. And notice even the femur looks much thinner as well. And then we look at a 70-year-old triathlete. I don't know if you could tell the difference between a 70-year-old triathlete and a 40-year-old triathlete. It's pretty tough to tell the difference. They're very similar. So is it primary aging or is it secondary aging, right? Secondary aging is really long-term poor lifestyle aging. If you stop doing anything at 40 and just are very sedentary, this could be your destiny here at 74. Now we know it's variable. Some people don't age that way for whatever reason. Their body protects their muscle tissue more so than others, but we know there's a lot of lifestyle factors. It's not just because you're 70, you're going to have poor muscle mass. In fact, when we look at some studies on sarcopenia, sarcopenia is the loss of muscle. This is a huge, huge thing for us to be thinking about. What we see is there's a huge degree of variability between individuals, right? It's perfectly fine. I don't know if I have no, I don't. Some of my other presentations, I think I've shown you guys. It's perfectly fine to put that line of best fit. That's acceptable in science. It's statistically accurate, and we say, right, 30% loss of muscle mass from age 50 to 70. But the reality is, it's very, very different person by person. It's very individualized. So when we, and we make this mistake in BMI all the time, and I see trainers all the time fighting about BMI online and stuff, and I'm like, you're misunderstanding. BMI is a population measure, not an individual measure. And same with sarcopenia. We know if we study enough people, thousands and thousands of people, we're going to see about a 30% decline in muscle mass over thousands and thousands of people. We might not see that for Maurice. Maurice might have a 10% decline, and Nikki might have a 50% decline, right? It's a huge degree of variability. Nikki's like, oh, that's bad news for me. Nikki, you really, really need to be strength training. Maurice, maybe it's not as critically important for him. But look at this individual up at the top, right? This is like my client Howard, had more muscle mass than he ever needed. He could decline at 30% till he's 100, and he's still going to be stronger than everybody in the room, right? Because look how much muscle mass he has. Whereas this person down here is already in trouble at 72, right? They're probably having trouble getting out of a chair. So huge degree of variability, and people are all over the chart on this. So we always have to remember that, sure, the norm, the average is this, but some clients are going to be above average, so they're losing more muscle mass. Other clients are going to be below average. And it's just something we have to be thinking about. And of course, how much muscle mass you start with makes a big difference too, right? I mean, if you start at 50, way up above, then your gradual decline is not as dramatic in terms of your function. You can still do everything you want to do. But if you start on the bottom half, if you're already deconditioned, if you're already a little bit weaker, maybe you're a smaller person to begin with, you haven't been as active, you've had some injuries, you've had cancer, the list can go on, you already have muscle mass stacked against you, then you really need to be working as hard as you can to maintain muscle mass. Typically, women are already at a disadvantage versus men in that they don't have as much muscle mass entering their 50s, and then menopause starts to mess things up for them hormonally, and all of a sudden they wind up at 55, 60 years old, and they don't have anywhere near the muscle mass they had in their 30s or 40s. Plus, a lot of women are smaller to begin with, right? 110, 120 pounds. It's not like they have the frames to just pack on tons of muscle, which makes me still chuckle when women in their 60s and 70s say, oh, but I don't want to get great, big, huge muscles. I'm always like, yeah, actually we do. We want to get you as muscular as we can. You're not going to turn into Arnold Schwarzenegger. You've seen too many magazine covers. Then if we look at leg power, this is really one of the more interesting things for Cody and I to be looking at these days. It's not just strength and muscle size. It's really power that then determines functional ability, right? It's can we move and use our strength with speed? That's how we do things, right? So our ability to get out of a chair fast, climb stairs, run across a parking lot. If we have to move quickly, chase the bus, beat someone to their seat in the movie theater, whatever it happens to be where we need to move quickly, leg power we see drops off much more so than leg strength and leg muscle area, a much steeper decline with age. When we look at strength, power, and function, we can see the relationship between leg power and physical performance is just more marked so than leg strength. Now, I'm not saying strength isn't important, it certainly is, but we notice time and time again, tandem gait, habitual gait, maximal gait, battery tests, power is far more significant. Barb, were you ever able to find Sue's picture? I have not yet, Barb. I will dig for that again and see if I can't post it in the Facebook group, because it is a good before and after picture. Hand grip strength, right? I mean, this is, again, it's a basic functional task. You can see with age, it really begins to decline, especially as we get to that 80 and over, right? Normal strength, intermediate strength, weak strength. You can see 80 and over, it's really starting to drop. And that's where we start to have trouble with things like opening jars and holding on to things and grasping things and, you know, heavy doors and just a lot of functional tasks. All of a sudden, I just don't have the strength in my hands to do it. It's a pretty basic activity of daily living impact, right? It's going to impact so many different things. So percentage of adults age 60 and over with difficulty rising from a chair by muscle strength. Again, we're looking, this is sort of interesting. We're looking at hand grip strength. We tested hand grip strength. And notice their ability to rise from a chair is impacted by their hand grip strength. Now, I'm assuming the researchers were looking for a correlation to, you know, hand grip strength to lower body strength, and they were finding it. Pretty interestingly, people with normal hand grip strength, much higher percentile, much better rising from a chair. And then they actually broke it down. If you look at the slide on the right, they break it out by race. So again, hand grip strength, it's a simple measure. It's not hard to measure. We can get a hand grip strength dynamometer. We can see where people are at hand grip strength. And for many people, it can be predictive and associated with lower body strength. As we're losing hand grip strength, we're likely to be losing lower body strength, which impacts function as well. So let's just look at the definition of sarcopenia. It does seem to be more dramatic after the age of 80. So it does seem to be more associated, again, that physiology of aging is a real concern. So sarcopenia is a progressive and generalized skeletal muscle disorder that is associated with increased likelihood of adverse outcomes, including falls, fractures, physical disability, and mortality. Low muscle strength is the primary parameter of sarcopenia. Muscle strength is presently the most reliable measure of muscle function. So it's hugely important. So whenever you hear us talking about how strength isn't the primary driver of function, it's one of many, right? It's the musculoskeletal domain. And sarcopenia, if you're in that category, it's certainly going to be one of the most critical things we need to be focused on training. Prevalence of sarcopenia in the elderly in the US. Now these are old numbers. This is really looking at our senior generation, not going to be applicable so much to baby boomers, but you can see it's not overly prevalent. 70 to 79-year-olds, we're looking at 7% of men and 11% of women. Pretty consistent with people over the age of 80. So it's not a everybody has this, right? That's the mistake sometimes we make, is we think, oh, well, everybody over 80 must be weak. No, that's really not the case. Everybody over 80 must have lost so much muscle. We're really talking about the 10% of the population that winds up falling in that frail category, right? They're so weak that we notice it, right? Like they look weak. We can almost visibly see it. They don't look like they have a lot of muscle mass. They visibly look like they might have trouble. I mean, we would almost stereotype them as to say, ma'am, do I need to help you? Or sir, do I need to help you out to your car with your groceries, right? We can sort of see it. They just don't have physical strength. Typically people, in this age range, in the 60s or sub 60s, have probably had some sort of a health condition, whether it's cancer or a stroke or some sort of significant life event, because typically we don't see sarcopenia under the age of 60 unless there's been, medication or a major illness. Prevalence of sarcopenia in different countries. Now, Japan, much higher prevalence. Some of that is believed to be to a much older society that have more people living into their 80s and 90s and a greater percentage of old people. So certainly much more there, but it could also be lifestyle factors, a number of different issues. You can see the UK, Taiwan, USA, fairly similar. So as we look at some European discussions on sarcopenia, there's a couple different points here, but I want to look at the second and the third one here. Second, sarcopenia is now considered a muscle disease or muscle failure, with low muscle strength overtaking the role of low muscle mass as a principal determinant. This change is expected to facilitate prompt identification of sarcopenia in practice. So there are some that are now considering essentially sarcopenia as a muscle wasting or muscle is failing to maintain its tissue and wasting away, which is not a normal part of aging. So there's going to be some muscle loss with age and lack of use, but some of the researchers are now pointing to sarcopenia is actually considered muscle tissue is failing, right? It's not maintaining itself and really doing what it should do. The third one here, sarcopenia is associated with low muscle quantity and quality, but these parameters are now used mainly in research rather than in clinical practice. Muscle mass and muscle quality are technically difficult to measure accurately. It really is very difficult for us in the field to measure muscle quality, right? Like we're not going to be taking muscle biopsies and cross-sectional pictures of people's muscle. All we can really determine is muscle mass and muscle strength. We can't necessarily tell the health and the quality of the muscle, right? Is the muscle striated with fat? You know, what does the quadricep muscle look like? So that tends to be a more clinical practice where they're doing muscle biopsies and, you know, MRIs and cross-sectional pictures of muscle mass, that sort of thing. So there's going to be more and more research coming out on sarcopenia. I encourage you to be looking for that, because what we're seeing is sarcopenia is a primary driver to major falls, major injuries. Really, in a lot of communities, sarcopenia is a major driver for, you know, you have to move into assisted living or a nursing home or long-term care facility because you don't have the muscle mass to take care of yourself, right? Like going to the bathroom is too dangerous because you don't have the muscle mass. So sarcopenia is something that we continue to see more and more research on, because you can live from 80 to 100 really well if you have enough muscle mass to do basic activities of daily living, right? Like cooking and cleaning and going to the bathroom and dressing yourself. And you don't have to be super strong, but you have to be strong enough to bathe yourself, dress yourself, go to the bathroom. Once sarcopenia gets to the level that you can't do those things, it's a tremendous loss of independence, but also a huge burden and cost to society. So if criteria 1, 2, and 3 are all met, sarcopenia is considered severe. So low muscle strength, low muscle quantity or quality, and low physical performance. It's sort of like the 3 strikes and you're out. If you have all 3 of these, you have sarcopenia at really the most severe quality or condition. So I'm only going to highlight this quickly because there's a lot going on here, but assessing muscle strength through grip strength and chair stand tests are simple, and pretty quickly we can determine if someone is normal, really no sarcopenia concerns, we can rescreen later, or they score low on those and we say, hey, they're sarcopenia probable. Now, unless you're in a clinic or a medical setting or a research setting, you're probably not going to get into the muscle quality. But you could get into muscle quantity for sure with bioelectric impedance, a DEXA, but obviously you're not going to be doing MRIs and CTs and some of these other things. So some of this gets onto the kind of the clinical. But you can look at the strength components that we can look at, right? How much difficulty do you have lifting and carrying 10 pounds? Some, none, a lot. Assistance in walking. How much difficulty do you have walking across the room? None, some, a lot. 0, 1, and 2. If you score 4 or higher on these 5 items, it's predictive of sarcopenia. Rise from a chair. You know, really we want to see, we don't want to see 1 on all 5 of these. If we see 1 on all 5 of these, if you're some on every category, how many times have you fallen in the past year? Some, you know, that's a 1. How much difficulty do you have climbing a flight of 10 stairs or 10 steps? Some, you know, if you're 1 on 5 of these or 4 of these, that's predictive of sarcopenia. So fairly quickly we can assess people with some, I mean, really you can do this as just a questionnaire, right? This is the SARC-F questionnaire. You don't even have to assess them. You're just asking them the questions, and you know if people are scoring 4 or higher. Muscle strength should be high on your your priority list, okay? Some more sarcopenia definitions: low muscle strength, the hand grip dynamometry. So that's your hand grip, strength test. Here are some norms that they're finding. Men, 27 kilograms of force, women 16. Chair stand 5. They're just doing 5 chair stands if that takes more than 15 seconds. And then low physical performance, they're looking at gait speed, the short performance battery that I mentioned earlier, the timed up and go, and the 400-meter walk test. 400 meters, that's like 1 lap at the track. Look at the time there, 6 minutes. I mean, that's not terribly fast for a quarter mile, 6 minutes. It's not even 3 miles an hour walking pace. So primary and secondary. Got to admit somebody else to the room here. So certainly there can be diseases, that are a primary cause of sarcopenia: inflammatory conditions, organ failure, an arthritis condition, neurological disorders such as MS, Parkinson's. There could be other diseases like cancer where we have to take medications that are ravaging our body. A lot of cancer medications are killing all of our tissues, and of course they will ravage our muscle tissue sometimes. Of course, inactivity, sedentary behavior, physical inactivity, limited mobility, bed rest, a variety of different reasons we might be sedentary. That can have a long-term secondary cause of sarcopenia. And of course, malnutrition can be a big factor if people are not eating a well-balanced diet. So again, sarcopenia can be caused by a lot of different factors. It's not just aging, but we do see that the aging-related sarcopenia, is something we need to be aware of. And most of that is caused by a variety of lifestyle issues, sedentary living being the primary one, but then there are other things as well, diseases that can come along. There are reasons why people have bed rest, right? Maybe you had a broken leg because you were in a car accident and you spent 3 to 4 months on bed rest and didn't ever recover from that, right? You came off of bed rest, just went back to normal sedentary lifestyle, and so you had a drop in muscle mass for 3 to 4 months, which essentially accelerated that long-term aging. So, and of course there's nutritional, which a lot of those can be linked to, vitamin deficiencies, a malabsorption issue, a gastrointestinal issue, like an irritable bowel syndrome, or there's just a variety. And of course, obviously eating disorders would certainly be an issue. And eating disorders, even young in life, can be an issue, right? So we see that sometimes male and female athletes, it's not always athletes, but male and female athletes sometimes suffer from eating disorders due to performance and maybe having to make weight for a certain activity or sport, or believing they need to perform at a certain weight. And so their poor nutrition or eating disorder for years of competition could have led to some sarcopenia. So let's look at the neuromuscular domain. Here's where we're going to see some of the gross motor type things, the movement things, the sensory losses, right? Fine motor skills are impaired, gross motor skills, reaction time, decreased movement speed, just don't move like I used to, not as agile or as quick as I used to be. The motor impulses are not quite as fast as they used to be. And so we see just little bit of losses in all of these areas that impact speed, agility, fine motor skills, all of these sorts of things. And of course, multi-sensory losses as well. My vision is not quite as sharp as it used to be. My visual reaction time, my visual recognition time, not quite the same. And so that impacts how I move and respond and react. And of course, the sensation in all of my touch points, right? My feet and my hands. And, when I'm reaching for something and grabbing it, maybe the sensation is not quite the same as it was when I was younger. right? We look at the visual losses. There's just a number of things happening, you know, major causes of severe vision loss, macular degeneration, diabetes, glaucoma. But cataracts is the most common and prevalent one we hear about all the time. And, you know, people have some blurring of their vision until they've, you know, finally have the cataracts fixed. And we see more significant visual losses in those really 75 and even 80 and up, where we start to see some visual impacts. That the eyes are not as quick to noticing, you know, what's happening in their peripheral. They don't necessarily respond to it, and so playing certain sports all of a sudden is impacted. You don't see the object or the ball coming from, you know, a different angle because your visual receptivity is just not quite the same. We see decreased joint position and joint motion sense, that proprioception, right? Our ankle talking to our knee, talking to our hip, telling our shoulder what we're going to do. And so all of a sudden serving a tennis ball doesn't feel as connected because my shoulder didn't quite get the sensation that, hey, I raised up on my tiptoes to serve, and my timing, right? We're not quite communicating through all those joints like we used to. Hearing loss is a factor. Definitely is still more common in men. The higher frequencies are the first to go. And this can impact a lot of different activities in the neuromuscular function. And of course, vestibular dysfunction, those are separate. Sometimes people think, oh, you have hearing loss. That's not the same function as vestibular function, but vestibular dysfunction is much more common as people get over the age of 70, right? That inner ear system that tells us, you know, hey, we're tipping forward, or we're moving fast, or you know, we're riding on a roller coaster. That vestibular function is just not as sharp as when it was young. We've all probably experienced this. We get to a certain age and we're like, you know, those going round and round spinning rides just aren't quite as fun as they used to be, because your vestibular function is not as fast as it used to be. And so the joy of, you know, being spun round and round and round just isn't there anymore. I still enjoy roller coasters, but the round and round rides, like, kids, you can do those on your own. I don't really need to do those. So, but that has a huge impact on fall risk as people get over the age of 70. And that's one of the things we see is it's not vestibular dysfunction as to why people are falling. It's because they have 10 to 20% loss of vestibular function, combined with decreased joint position, combined with visual losses, combined with sarcopenia, it's all starting to stack against them, right? And so pretty soon you realize, well, yeah, I mean, it's sort of the perfect formula for increasing your fall risk. We've made everything harder. Cardiovascular, so we've shifted another domain here. We're seeing a decline in maximal oxygen consumption. VO2 maxes go down. They just simply go down. Our max heart rate goes down. We see a decrease in cardiac output, a decrease in the arteriovenous oxygen difference. I mean, all of our performance variables for cardiovascular begin to decline with age. Decrease in left ventricular ejection fraction. That's a mouthful. Basically what's happening is, as our heart is aging, you know, our heart rate comes down a little bit, the maximal heart rate, and on top of that, our maximal cardiac output lessens. So our heart's ability to pump the quantity of blood with the quantity of pressure and consistency goes down, right? Our blood vessels become thicker and stiffer. Our classic cardiovascular disease, essentially arteriosclerosis, right? Our blood vessels simply are not as pliable as they used to be. The hoses are getting thicker and stiffer. There's an increased risk of hypertension, increased risk of stroke. This is usually the time in which people are like, man, this physiology of aging stuff's kind of depressing. Well, yeah, it is. I mean, our bodies are aging. So our 80-year-old heart is not the same as a 20-year-old heart. And in fact, I believe it's part of why it's even more important. We recommend people exercise almost every single day, because a 20-year-old, they can probably get away with weeks of not being physically active. Their cardiovascular system is not dramatically changing, right? Their cardiac output's still good. Their maximal oxygen consumption hasn't changed. But for someone in their 80s, they need to be doing this every day to maintain their cardiovascular health, to maintain their heart health, to maintain all these blood vessels need to be worked, right? We need to continue to keep them as pliable and healthy as possible. So I think it's really important we encourage people, even if it's just take a walk every day, right? It doesn't have to be intense cardiovascular training every day, but do something to get your heart rate up so your heart muscle's working, your cardiovascular system's working, because we've got to maintain our maximal oxygen consumption to some level, right? When your VO2 max gets below 20, you're really going to have trouble with things like going for hikes and bike rides and things that require any sort of cardiovascular fitness. Doesn't mean you have to be able to still run a marathon, but it's sure nice to be able to walk 3 or 4 miles. So I didn't have much on cardiovascular. There's a little bit more in the reading material, but I mean, it's kind of the basic stuff that we kind of know, right? Max heart rate goes down, max cardiac output goes down, really maximal performance goes down. But it doesn't mean we can't still have great performance. I mean, we see people in their 70s completing full Ironman triathlons. So it's not like your cardiovascular system just completely falls off a cliff or anything. It's just not the same, obviously, as when you're younger. The balance and mobility domain, again, this is really a multifactorial system, right? There's so many things going on here, multiple systems affected that feed into balance and mobility. I think a lot of them come into play in this particular domain. Use of walking aids actually typically increase fall risk. Now, I don't know if we really know from the research if it's the use of the walking aid or if it's because you're using a walking aid, you're at a increased fall risk. It's not completely clear, but it does appear that using a walker, using a cane, those things are not in any way reducing people's fall risk. And then polypharmacy is a real issue. We're finally starting to see some physicians realize as their patients get into their 80s, they need to figure out how to get them reducing their medications, not increasing. It's really easy to just add one more for your arthritis or your high cholesterol or your high blood pressure. We're seeing more movement now towards, well, you're in your 80s, so let's take you off of the cholesterol meds. Let's take you off of some of these other meds, because once somebody gets to 4 medications or more, their fall risk really goes up. There's just so many medications going on that it can impact your blood pressure levels, dizziness, orientation. You know, sometimes people, they have these blackout falls. They don't remember falling. They don't even remember falling. They don't even know what happened, and all of a sudden they're on the floor. So something we want to be conscious of, and certainly something we want to be conscious of training clients. How many medications are you on? I kind of need to know. So huge concern, falling. This is going to be an ongoing concern probably for the rest of our careers. Sadly, these numbers are only going to climb every decade because our population is getting older, and there's going to be a greater percentage of people. An older adult falls every second of every day, but less than half talk to their doctor about their fall. So we know a lot of falls are not even being reported. Of the falls that are being reported, there's a gigantic number. We estimate there's about 29 million older adult falls annually. That's an estimate. 24% of those falls require some sort of medical treatment. And we know there's approximately 2 million serious injury falls showing up at the emergency room. So some of these falls are, you know, I go and I see the doctor the next day because I think I sprained my wrist, or, you know, maybe I broke my finger, or I hit my head. But it's the 2 million folks showing up at the ER that have had, you know, a hip fracture, a vertebral fracture, a head fracture, you know, a dislocated shoulder, a major injury that requires hospitalization and major treatment. And these are costing billions. Somewhere in the neighborhood of $50 billion a year, the National Council on Aging says. It is Falls Prevention Week this week, so it's a major issue. We see it's gonna really climb in the next 10 years. I mean, we go from 7 million injuries to 12 million injuries, 29 million falls to 49 million falls. It's staggering. So the 31 billion is based on 2014 numbers. We're at about 50 billion now, and by 2030 they're they really don't know, but it could exceed 100 billion. That's pretty staggering when you think about the vast majority of that's going on our Medicare system. So it's something that we're all paying for essentially. CDC has some fall statistics. Every second of every day, like I said, an older adult suffers a fall. 30 million older adults approximately falling, resulting in about 30,000 deaths. We don't know for sure on the death statistics because sometimes people die 5 to 7 days later and it doesn't always get counted as a fall, but typically the fall death statistics are people with head and neck injuries, typically within a day or two of their fall, right? It was clear that that was their cause of death. The tricky part is that about 300,000 people are hospitalized for hip fractures and almost 100,000 of them die within a year, but that of course is never listed as their cause of death, right? So it can lead to a big life change in less than 12 months. So more than 95% of hip fractures are caused by falling, usually by falling sideways, right? They fall sideways onto their hip. That's the typically forward falls are wrist fractures, shoulder dislocations, collarbone fractures, not hips, right? We wind up with our hands out in front. Forward and backward falls can actually be the most deadly because if we hit our head, whereas falling sideways, we typically wind up breaking our hip, not injuring our head. Women fall more often than men and account for 3/4 of all hip fractures. In fact, a woman is far more likely, I believe it's 2 times as likely to have to suffer from a hip fracture than to ever suffer from breast cancer. So interesting tidbit there. But I'm not, we're heading into October here, not by any way am I trying to minimize breast cancer. To me, it's just interesting that we don't hear much about women and hip fractures like we do women and breast cancer. So, and I think it's a huge quality of life issue that we need to work on because I think a lot of women in their 70s and 80s could live 5, 10, 15 more years of good quality of life if they're training and they avoid these falls that lead to hip fractures, which for many of them are a significant change. In fact, 50% of hip fractures never fully recover at all. They wind up either in full-time care, nursing home, have caregiver at home, or they die within 12 months. So it's a significant problem. So I'm going to jump through this. You guys can look up charts on the death statistics. I actually don't think the deaths capture it, right? When we talk about 30,000 deaths, I mean, that's terrible. It's sad. It's sort of odd that over the age of 65, there's got to be a joke in here somewhere, right? Like more people are dying from falling than from driving a car. We always think that older people can't drive, right? Actually, they can't stay upright. It's sort of crazy that from age 1 to 64, the most common accidental death is car accident. From age 65 and up, it's falling. But I think these numbers minimize because when we talk about 30,000 deaths versus 30 million falls, it doesn't even capture it, right? It really doesn't compute. And when we look at 2 million people showing up to the emergency room with serious injuries, that's a far bigger number than 30,000 deaths, far, far bigger. So I don't think the deaths really capture, while this is tragic and certainly terrible, I think the 2 million injuries is an overwhelming number. Fall deaths rates, I mean, they're climbing. They're going to keep climbing. Our country's getting older. 7 fall deaths every hour by 2030. It's going to be a significant issue and continue to climb. We're probably going to get by 2030 to the numbers of 60, 70,000 a year, where falling is going to start showing up on our top 10 or 20 causes of death, which is just sort of staggering. So it's going to continue to climb as our population lives longer and gets older. The death spiral, like I sort of hinted at this, right? A person falls or almost falls, then they're afraid of falling, or they fall and they have an injury. And so then because of that, they don't want to do things. They become less active. This loss of movement leads to accelerated physiologic loss, reduced mobility, physical fitness. This person is now at a higher risk of falling than when they started. And it's the wrong response to I've fallen and I can't get up, right? It's no, you've fallen and you got to get back up and you got to start training and you got to get after it as aggressively as possible. Not impose activity limitations, not let your kids tell you, well, mom, maybe you shouldn't go to the grocery store anymore, not reduce, 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 because then we go downhill really fast. And we see the person go from limited independence to completely dependent, now at a huge risk for a serious fall. And this is in the research sadly called the death spiral. And we see this especially with people that have had a major injury fall, right? They fall and they break their wrist, they fall and they dislocate their collarbone, they fall and they break their hip. Well, now they're afraid to do any of those activities that may have led to that, right? Which could be going to play bridge or going to church or whatever it was. And now they're socially isolated. They don't go do the things that they normally did, and they decline really, really quickly. And we go, how on earth is it that grandma was cooking Thanksgiving last year and now this Thanksgiving she's gone, right? And it happens that fast in a 12-month spiral because people decline really, really fast. And some of you probably know people or have seen this or have had even clients that this has happened to. All right, I got to keep watch on the time here. ABCs of why older adults fall. I didn't touch anything. How did I do that? Usually there's a risk factor that causes a fall, right? Age is certainly a risk factor. Over the age of 75 is a risk factor. Ambulatory status. How well is somebody moving or walking across a room? Do they use an assistive device, a cane or a walker? Balance, behavior at time of the fall, chronic conditions, cognitive deficits, drugs, exercise level, environment. People have terrible home environments with multiple flooring and different thresholds they have to walk through, and they have strips, transition strips from carpet to hardwood, too many tripping hazards all over. And then you throw in rugs and all sorts of different things they want to throw out on the floor, and coffee tables. And I mean, it's like an obstacle course in some people's living room, but they are attached to these things and these rugs and these tables and these obstacles. So footwear, of course, flooring in and of itself can be an issue. Some flooring is more slippery than others. Some flooring changes with environmental conditions, right? It's a little bit humid or it's colder today, the flooring gets more slippery. We've all experienced this in certain homes where it's like, wow, this floor is really slick in the morning, but not so much in the afternoon. And of course, then you get into basement flooring, which, you know, might not be safe flooring, or so there's a lot of different environmental factors, and those are critical. Footwear is sort of a funny one. You know, I mean, I think sometimes just people get in the habit of wearing certain sorts of socks that aren't helping them with traction on slippery floors. They like to wear house slippers, whatever it happens to be. And a lot of times the footwear is part of the problem. Let's talk about the cognitive piece. This is definitely kind of discouraging as well. We know and we've seen people live well to 100 and not have much cognitive impairment at all. So we know that dementia and cognitive impairment do not have to be normal conditions of the aging process. It's not just to be 85 is to be cognitively impaired. It does not have to be that way. Because we also see cognitive impairment, dementia, and even Alzheimer's with people in their 50s. So we know that's not a normal condition of the aging process either. Cardiovascular disease and dementia are definitely closely linked. We do see, and we're seeing more and more, a link between brain health and overall fitness health. Cardiovascular health seems to be very protective, as does sarcopenia and muscle mass. In fact, there's more and more research coming out showing links between strength training and brain fitness. The more muscle activity you're getting, resistance training activity, the more preventative and protective it seems to be for your brain density. Typically, mild decreases in visual and verbal memory, visuospatial abilities, and immediate memory. These are sort of normal losses with age. Increase in crystallized intelligence, acquired knowledge and expertise, such as in an occupation. So it's sort of interesting. With age, those things actually can increase. And you know, something that you mastered for 30, 40 years, that part of your intelligence seems to increase. But there seems to be some decrease in the fluid intelligence, right? That novel problem solving and mental speed. So certain tasks that are new or novel to you, you're like, why is it I just can't quite figure out this task? You don't have quite the same fluid intelligence as when you're younger. Some decrease in executive function. So things like planning, working memory, initiating, that should say initiating an activity, not and. Inhibition. This one here is the one that we typically see can become the most troublesome with people with Alzheimer's, right? When they have troubles with their working memory, initiating an activity, and inhibition. Inhibition is a big one. All of a sudden, that decrease in executive function can make them really difficult to reason with, to deal with, right? You're trying to plan an activity, planning, that form of executive function isn't there, working memory of what it takes to do these activities and initiate an activity. It can be as simple as just going to the grocery store, which doesn't take a lot of planning, right? But those steps of, okay, we're going to make a list, we're going to get in the car, we're going to, you have steps to do, can be a challenge. Depression is more common in hospitalized older adults, disabled, poor health, chronic pain, and certain medications. So depression's still a huge concern. Seems to be a little bit more so in a lot of men, and we see a huge suicide rate. In fact, the 65 plus age group has the highest suicide rate. Sort of staggering to think. As big a problem as suicide is in our country, it's not going away with age. In fact, the 65 and older group has a high suicide rate for a variety of reasons. And so mental health is still a huge concern. Now, for many individuals, there are a number of challenging losses they're dealing with. Oftentimes it's the loss of a spouse and the inability to deal with that. The depression becomes overwhelming, and the desire to continue to live without that partner seems overwhelming. Whereas for someone in their 30s or 40s, they realize there's a lot of life ahead. Their ability to grieve and get over that can be different from someone in their 70s and 80s. There's a new case of dementia somewhere in the world every 4 seconds. By 2050, we estimate there'll be 135 million people worldwide with dementia. And the costs for dementia are staggering in terms of caregiving, loss of income opportunity for both the person suffering from dementia, but also from the caregiver, as many family members will be dealing with the caregiving. Primary risk factors for cognitive impairment and dementia. Again, this is not a normal part of aging, right? If we look at the normal brain there versus the Alzheimer's disease brain, they don't look the same. It's not normal part of aging. Smoking is a huge risk factor. Physical inactivity, sedentary lifestyle, poor diet, these are significant risk factors. And then physiological conditions, cardiovascular disease, type 2 diabetes, hypertension, high blood cholesterol, obesity, and we're starting to see people talk about type 3 diabetes, which we think really affects the brain. And so blood sugars, blood pressure, all of these things seem to be impacting long-term brain health. So again, fitness seems to be a huge protective of our brain matter and our brain mass. So when we look at cognitive decline, I gotta watch the time here. So everyone experiences some slight cognitive changes during aging. I mean, I can even tell at 45, my brain's not the same as when I was 25, certainly not as fast as when I was 15. We have this silent preclinical phase, right? The brain changes without any measurable symptoms. I probably don't even know if I could measure my difference, but I know it's there. I know it's not the same. My reading comprehension isn't the same. I used to have amazing reading comprehension. I could read something, remember it. It was locked away. Now I can read something and be like, yeah, I read that book. I don't remember it. Can't comprehend it quite the same. So mild cognitive impairment, for most of us, we don't start to see that until later in life. And we certainly hope that doesn't come on until ideally into our 70s. For some people, though, it certainly could be in their 40s or 50s if, again, they're not physically active and their diet is poor, their sleep habits are poor, they're smokers. There's a number of they've had multiple concussions. There's a number of reasons why we could get mild cognitive impairment younger. We start to see one or more cognitive domains impaired. So certain things we just start to notice. Executive function isn't quite as good, or working memory is not quite as good. And then obviously it gets steeper as we get to mild and moderate cognitive impairment to the level of dementia, where cognitive impairment is now severe enough to interfere with everyday abilities, right? My ability to remember things. And we're not talking about I can't find my wallet or my phone, right? I mean, we all do that just because we forgot where we left it. We're talking about things like, I can't remember what day it is, and, not sure what I'm supposed to be doing today. And, it starts to interfere with basic like, we go into the kitchen. I can't remember why I went into the kitchen. I go back to the bedroom, and now I lost recognition of the fact that I came back to the bedroom to try to figure out why I went to the kitchen, right? So we do those sorts of things, right? I'll go into the kitchen and be like, I can't remember what I came in here for. It's completely different than compared to someone with dementia, where they go back to their bedroom and that they now don't even remember that they were confused about why they went into the kitchen. And so, of course, these things get really difficult when we're caring for these people. And they don't always even realize what's happening to them, right? It can be quite confusing. A personal, experience is, something like we're going to the beach and we're going this way, and all of a sudden the person's going that way, right? It's like there's two access points to the beach and we're going here, and I don't know why, but they're going to the wrong one, right? And then you sort of have to redirect them. And then, of course, they get upset because they think you're going to the wrong one. Well, why are we not all going over here? It's like, well, because we all agreed that we were going to go to the beach through this access point, so, and it can be pretty challenging. So there's lots of information. Our brain health trainer program goes deep dive into the cognitive area. There's so many different parts of the brain that can be affected. Age certainly hinders attention and the ability to switch tasks and divide attention. I've certainly seen this, and you can see this training clients, right? Their ability to divide attention from focused on you to maybe what another client is doing, to maybe what music is coming on overhead, to maybe a new person walking in the door, to what's on TV. Oh, there's a new announcement breaking on the news. They can't divide their attention to all those things, right? There's too many things. And their ability to task switch from having a conversation with a client to the trainer to watching something on TV, their ability to task switch is greatly hindered as well. Now, a lot of people are aware of this. They realize they get to a certain age and multitasking is just not something they can do, right? They have to do the one thing they're focused on. They can't divide their attention, right? So they might be cooking in the kitchen, and don't talk to me while I'm cooking. I have to do this thing. I can't be distracted, right? Working memory changes, processing speed, just a little bit slower. It's not huge, it's just a little bit slower. Visual perceptual abilities, problem solving and decision making, right? These things are declining. All right, I'm going to move on here because we're going to run out of time. I was afraid I wasn't going to get to the understanding adults, and I'm probably not. Let's see how much more we got here. Yeah, we still have quite a bit here. Oh, no, we don't. We just have 5 more slides. So we'll finish this one, and we'll probably have to decide if we want to come back and do the understanding mature adults. So physical activity is a huge impact on the brain in so many different ways. Structural changes, molecular changes, physical activity is just overwhelmingly, the best thing we can be doing for our brain. Probably the next best thing is consistent rest and sleep, improvements in mood, improvements in mental health, but also neural changes. We see neurogenesis, the brain can actually grow, and physical activity is a huge benefit towards that. So just a simple image here showing what we want to be happening, and exercise is the primary driver for this. So if we want our brains to be growing and stimulated, we have to be moving. And then we also have to be moving in new ways, right? So it's sort of like when little kids learn how to skip, hop, jump, gallop, all these sorts of things, dance. We have to be doing new movement patterns to get this brain growth. Effects of angiogenesis. So angiogenesis is essentially we're growing more blood flow. We're stimulating the brain is basically saying, hey, we better increase some more blood flow to these different areas of the brain based on all the exercise and movement patterns, right? You take up tennis or pickleball or a new sport, and all of a sudden you start to develop more brain neural patterns for that, and exercise stimulates growth in vascular networks. So that's really good because we want more blood flow to our brain. So that's a key part of it as well. Exercise is really, really important for that. So there is a tie, and this is, I think, a lot of what we see, the connection to cardiovascular health to brain health, because if we're moving a lot and maintaining our cardiovascular system, we're going to maintain the blood flow to our brain, which of course is going to help our brain stay younger. This is from Harvard University. The brain's ability to change in response to experiences versus the amount of effort such change requires. You can see that shifts quite a bit with age, right? The brain's ability to in response to experiences, and then the amount of effort such change requires. So you can see right around 30 is kind of where those cross. All right. Now, I'm out of time to do the understanding mature adults. That one, I want to come back and do that with you guys, so I'll probably schedule that for next week. There's no reason why we can't keep the fun times rolling here. So just to kind of give you a quick overview of that, you guys, can you still see my screen? Make sure you can see this. Okay, so this one is really where we talk about the aging world and understanding the aging world and who are these adults. So I do want to cover this. When I realized I put both these down at the same, I was like, I don't think I can get 2-hour lectures in, and I couldn't. So, but we really want to talk about, you know, attitudes. Why is the world's population aging so rapidly? Why is our country getting so much older, like we've never seen before? And so we'll talk about that. We'll also talk about the economic impacts of that, which I think are significant. We look at the economic activity of the 50-plus population in the U.S. alone. It's the third largest economy in the world, but we also have to understand what they're thinking about in their buying behavior. So we'll cover that next week. Any critical questions right now? Lori, thanks for offering more next week. Let's just take it to a vote right now. Pull up my calendar here, and I personally like the 1:30 Eastern time. I can do Monday or Wednesday. Is there a preference for next week, Monday or Wednesday? You guys can comment in the chat. I'll probably just go with whichever one's most popular. So I'm going to type in Monday or Wednesday. I'll see what questions we've got. Sorry if you couldn't see my slide. I was just showing some overviews of the talk I'll do next week. Nikki, my mother's osteoporosis was so severe, she was just walking when her femur just snapped and she fell. She did live an active life until 91 though. Yeah, for someone with severe osteoporosis, that sort of thing can happen. It's not very common, and it can lead to that sort of stereotypical, well, did they fall and break their hip, or did their hip break and they fell? It's very rare that someone's hip breaks and they fall. It takes typically a fall to break the head of your femur. But if you have severe osteoporosis, that certainly could happen. Kathy, will you be able to share this PowerPoint with us? Yes, I will post it in the Facebook group, so it'll be available there later, and I'll post next week's as well. Wednesday, Monday. It's pretty, look. Which one's the Jewish holiday, Wednesday or Monday? staff family. I can't remember your name, sorry.
It's Tammy. It's Monday.
Tammy, that's right. I was going to say Tammy. Oh, Monday's Yom Kippur. Okay, then Wednesday it is. So that trumps those of you requesting Monday. So we'll do it Wednesday at 1:30, and we'll talk about understanding the mature adult. So we'll post this recording later, and for those of you watching the recording, and I'm sure there are some of you, we'll do one more session next Wednesday at 1:30 Eastern on understanding the mature adult. Now, sort of interestingly, we sort of went in sort of reverse order. I don't know if you guys have picked up on this, but physiology of aging and understanding mature adults, you guys should have already done. That's like module 1 and 2. You should be well past that, past quiz 1. We've done fitness assessments. We've done the functional aging training model. Those are in the first section. And then section 2 was the functional movements, the progressions, the regressions, all the fun stuff that people think of, the exercise movements. You should all be past that too, and on to the last section and getting ready to actually get certified, which is what the ultimate goal is, right? So you're doing this to get the certification, get your CEU certificates and all of that. So I will see you next Wednesday, same time, 1:30 Eastern. We'll post the Zoom link in the Facebook group, and we'll do the understanding mature adults then. So, all right, everyone, have a great rest of your week.